Today's topic has a big question. Labor analgesia. Is it really required? See, this is the beautiful Shimoga airport, which is a wonderful airport today. In 2010, when the concept of this airport was floated with a population of around less than 3 lakh people were wondering why there should be an airport required for this small city. But this one man's conviction, the airport is inaugurated on the 27th of February 2023. And today, in 3 years down the line, this airport is connected with 5 cities in around Bengaluru, Hyderabad, Chennai, Goa, and Tirupati. And it is one of the fairly reasonably busy airports. So people may think that it is not required at all. No, when you start doing it, then it becomes essential. Now the question is, do parturients require pain relief at all? Now, before I answer this question, let's go by this. When do we ask for pain relief, analgesia? When do we really ask for it? Pinch painful? It is, isn't it? But have you ever seen somebody giving local blocks for these situations? No, isn't it? It doesn't require at all. How about this one? See, the first time I used a local anesthetic was when I was a house surgeon, when the rule was that you get a scorpion bite in the toe or in the finger, give a digital block. So I have given a digital block as a house surgeon itself. So what is it then? It is the intensity of pain that determines a requirement of analgesia. When pain becomes intolerable, you ask for relief. Okay? Now, with this in background, let's keep this at one level. Melzack and Torgerson at the McGill University, Quebec, Canada, they wanted to quantify pain. Say somebody says, I have pain. Another person says that I have more pain. I have severe headache. Now, which one is more than the other? Now, how to quantify it? For that, they interviewed 47,000 subjects over a period of 5 years who all attended the emergency room with some kinds of aches and pains. They zeroed on about 247 people finally, and all the pains and aches were classified into 3 groups: labor pains, pain syndromes, which are chronic pains, and the traumatic pain. To quantify the intensity of pain, to really quantify the intensity of pain, now they formed a scale. And this is the most important McGill pain questionnaire. Now, this is a scale of 0 to 50, where 0 is considered as zero, no pain at all, and 50 is considered as the worst ever pain one can imagine. And they wanted every individual to point where the intensity of pain lies on the scale. Now, to their surprise, you know what happened? The labor pains, whatever kind of labor they are in, and the digital amputation of the digit, traumatic digital amputation, were of the same intensity, lying somewhere between 30 and 40. Now, this was their finding. Now, with this in background, let's see. Let me ask each one of you one question. How many of you believe that anesthesia is mandatory for this procedure? Just chopping it off, digital amputation. How many of you believe that anesthesia is mandatory for this? I'm sure. Can it be done this way? 4 people holding on all places and then chopping it off? Nobody agrees, right? So everybody says that anesthesia is mandatory for this procedure. Now, let me give you another clinical situation. A primary in labor, 4 centimeter dilated. Now, I want to ask you a question, very sincere question. How many of you believe that labor analgesia is mandatory for this lady? Without it, she cannot deliver at all. Nobody says that it is mandatory. It is not mandatory. It is only optional. If Dr. Sujata is free, call her. Somebody else is free, call her. If it is possible, give her a relief. Otherwise, no problem at all. Anyway, she is going to deliver. Now, this is the concept. 2 pains of equal intensity, and one people definitely say that anesthesia or analgesia is mandatory, and the other they say it is optional. Hai to de do. Now, why is this discrimination? The reasons are many. Why is this discrimination? I have a few reasons why this discrimination has become part of our life. The first one is that labor pain is physiological. अरे शादी कर दिया, प्रेग्नेंट हो जाता है, प्रेग्नेंट हुआ तो लेबर पेन आ जाता है, बच्चा होना है ना. So labor pain is physiological. It is a physiology. Everybody gets it. So that is what people think. Second one is that it is inevitable. When I say inevitable, I'll give you one example. Supposing you go to a general surgeon with a renal colic. The surgeon says that ureteroscopic removal of the stone has to be done. So you say that my sister is going to be, I have a marriage at home. My sister is, getting married. So I would like to postpone this. Can I go home and come back? He will give you some analgesic, intravenous, 1 minute rakhega, fluids dega. He will advise you plenty of oral fluids and send you home. And you can come back after 15 days. Supposing Primi comes in labor and says that my sister is getting married day after tomorrow. Can I come and deliver after 2 days? It doesn't happen. No. Once you are pregnant and you are in labor, pain ends with delivery only. So labor pains, inevitable situation. So whether there is an anesthetist available, whether epidural is available or not, no question asked. Delivery pain is going to be there and you are going to deliver. This is what is inevitable means. It is universal, affecting practically all women, irrespective of caste, creed, race, nationality, nothing. Nothing matters. Pregnant, in labor, labor pains. And you see, it affects only women. Men don't become pregnant, you see. That is why you know the sex ratio. All of you know the sex ratio. So they don't even have a simple majority. Bas. So they stand for elections, you lose it. That's it. You cannot have majority also. And even amongst women, only those fraction who are in the reproductive age group are the ones who are going to suffer. Others won't. As long as she is a daughter-in-law, she keeps asking, we want epidural, darad hai, hota hai, and things like that. The moment she becomes daughter-in-law, becomes mother-in-law, she joins the people on the other hand. And she will start asking, why? Why epidural? Why pain relief? I delivered without epidural. My mother delivered 10 times without epidural. What is the problem? This is what happens. So roughly, they have only roughly 8% of the population only. And that is the reason why they are not heard of. That is, their voice is not heard. And there is one more reason. This is the only pain. You see, this is the only pain, labor pain, brings joy in the family. You go and tell in your family, my sister is having appendicitis, acute abdominal pain. Anybody will jump with joy? No. But you go and say, my sister is in labor. She is having labor pains. Everybody will be jumping with joy. Arey, bachcha aa jayega. See, she is in pain. So that is what is another reason. More important reason is the outcome. Labor pain is the only pain which has an attractive outcome. Baby comes out, you see, all the smiles, the cry, the everything, the games, play, everything that the baby does. The mother is so very happy that she forgets the labor pains, and within 2 years, she is ready with the obstetrician. She comes back with the missed period. She wants to have one more baby. So this is one of the most important reasons why labor analgesia is not very popular. So I recommend an epidural, at least until they are off to school. See, this is what attitude should come. So we as doctor community should make a decision on whether we should give epidural or not. My journey started off somewhere in 2002, 25 years ago, about 24 years ago. I went to Fernandez Hospital to learn labor analgesia, and I came back and we formed a group, 2 obstetricians and myself. 3 of us joined and formed Janani Painless Labor Center. We started our Painless Labor Center, and we added a pediatrician, we added another anesthesiologist, and then one more pediatrician. The group went on getting expanded. And you see the anesthetist, that lady there at the corner, and that girl, that baby, I had given epidural for her delivery, and she delivered under my care, and she joined me later on as a partner. Now, this is a pretty big group. Now, but for a few people whom you're seeing, you might probably recognize Dr. Sunil Pandya and his wife there, Evron Neerlesh Rafte, and a few others. Barring that, all others are my partners. So we as a doctor community, especially as obstetric anesthesiologists, should make a decision whether we give epidural or not. Whether we give epidural or not, whether we attend obstetric anesthesia national conference or not, and get some tips in obstetric anesthesia. The best compliment from a satisfied mother is this. See, about 20 years ago, I had given an epidural, and she had come back for her follow-up, and she wanted me to be in the outpatient with the obstetrician. Now, she showed me this. Then I asked her, she said she was so very happy with the epidural. And then I asked her, can I take a picture of this? She said, why you want to take a picture? I have posted it on the net. So you go and see, check on the net, this picture is there. So she was my patient who had an epidural with me. Okay. Now, so we have different techniques, of quite a few techniques for labor analgesia. You can classify them to pharmacological and non-pharmacological. Amongst the non-pharmacological, there are plenty of techniques. Pharmacological, you have the inhalationals, the systemic analgesics, and the regional anesthesia. And today's talk, I'm going to restrict myself with the regional techniques only. The other techniques I'm not going to touch upon. So before that, let's see what is an ideal labor analgesic. An ideal labor analgesic, let's see the nose, what it should not have. It's not supposed to have any ill effect on the fetus, no ill effect on the mother. It does not interfere with the progress of labor, does not increase the incidence of caesarean sections, does not increase the incidence of instrumental delivery. This is nose. So that means that the passage, the cervical canal, the passenger, the baby, and finally the expulsive forces. All these three things should not be affected by our technique. That is supposed to be for the ideal labor analgesic. Yet it should have a few things. Yes, what is it? Number one, it should give an excellent analgesia, keep the mother fully awake, and allow her to participate in the process of labor. Now, this is giving an excellent maternal satisfaction. Now, epidural labor analgesia comes somewhere near to the ideal, with C-section rates not altered, minimal increase in the instrumental deliveries, and no effect on the fetus. Excellent analgesia and good maternal satisfaction. And that's why this is the gold standard for this procedure. So now, amongst the regional anesthesia, let's see what are all the techniques. Which are the techniques currently in use? The caudal epidural, for obvious reasons like, the hygienic reasons, you cannot keep the laboring mother. Can you keep the caudal space clean, hygienic? It's not possible. And the amount, the quantity of the local anesthetic required from the caudal catheter for first stage labor is extremely high. And these are the reasons why caudal is not being practiced these days. Lumbar sympathetic block, bilateral block is required. Technically, it's difficult, covers only the first stage in spite of all this. So that is also not being used. Paracervical block, it is also not very useful. Pudendal nerve block, bilateral block is required and covers only in the second stage. And these reasons why these three techniques are not being used. So that leaves us with the lumbar epidural, combined spinal epidural, and the single shot spinal block. And to which a dural puncture epidural analgesia is also added. So these are the four topics, four systems, techniques, which I am going to discuss. Now, when I say that there are four techniques that are there, now the question is how to decide on which one to choose. We have four techniques, regionals. Now, which one to decide? Now, let's go one by one and see what are the indications for each one of them. Let's start with the combined spinal epidural. In combined spinal epidural, you know very well, all of you know how a combined spinal epidural is done. There is a spinal component, there is an epidural component. Okay? Now, two indications are there for CSE. Definite two indications. That is, one is very early in labor. What is happening in very early labor? It is the visceral component only that is very strong. The pain is mainly visceral component. The somatic component is not much. At that time, an intrathecal narcotic alone would suffice, which will work for about 3 to 4 hours. So if you give the intrathecal either fentanyl or sufentanil and wait for about 3-4 hours, the analgesia is good enough for that period of time. And when once the pain is intolerable, she enters into an active phase of the first stage, then you can supplement with the epidural catheter, which you have already used. And the question is, so this technique is also synonymous with the walking epidural, because giving fentanyl intrathecal will not produce any kind of motor blocks. So because there is no motor block, she can be walking around ambulant. And then you take over to epidural labor analgesia. The second indication is very late in labor. Very late in labor, what is happening is that she is shouting, she is jumping, she is not allowing you to do epidurals also. All of us, we all being the private practice, all of us are good at giving spinals. So all that you need to do is, even when the patient is jumping, you go ahead and give just a spinal. Need not be the CSE kit. Give a spinal with a narcotic, about 20 mics of fentanyl, and a local anesthetic, about 1.5 to 2 milligrams of bupivacaine heavy. Give spinal, she is in analgesia. Now she will listen to you. Now you go ahead and place the epidural catheter. After that, maybe once the spinal effect wears off, you can take over the epidural. So one is very early in labor, one is late in labor. CSE is an indication. The dosage, I think all of you know, fentanyl 20 mics with bupivacaine heavy 0.5%. The regular spinal ampule 1 to 1.5 milligrams, that is 0.2 to 0.3 ml only, and that will suffice for analgesia. So very early in labor, late in labor. The second one is dural puncture epidural analgesia. My good friend Dr. Lawrence Sain, who is professor of anesthesiology at the Massachusetts General Hospital, Boston, and he is also the editor of the last 3 editions of Chestnut Obstetric Anesthesia textbook. He's a highly recognized person, and he's going to be one of the faculty in AOA this year at Shimoga. It is his brainchild. Now, so I'll tell you what it is. In epidural, you know what we do. We place an epidural catheter, we place the drug. In CSE, what we are doing? In CSE, we are taking the epidural, we place a spinal drug, okay, component, and then continue with the epidural content. In dural puncture epidural, all that we are doing is that we take a 26 or 27 gauge needle through the needle, make a rent in the dura. Don't put any drug there. Just a rent there and come out. Just a rent in the dura and come out. And then place the drug epidural. Through that hole, some amount of drug seeps into the subarachnoid space, and that is his concept. The quality of analgesia is better, but it is not that very popular even now. Already in Massachusetts itself, they are not using it on a routine basis. So it's not a very useful technique. The third technique is single short spine. In fact, probably I will tell you the indications. Very late in labor. That is, say in about head and perineum, or at least 8 centimeter dilated in a multipara, in about half an hour to 45 minutes, the patient is going to deliver. And she wants some kind of analgesia at any cost. So you go ahead and give a spinal. Simple spinal only with the same dosage which I have asked. Don't put in an epidural catheter also. They will be the most thankful people. They know they would have experienced very bad labor pains. That is why they will be very happy with this. When you give the single short spinal, half an hour you have given analgesia. For 8 hours she has suffered, and for half an hour she will be the most thankful person. Now, this is one of the feedbacks one of my patient has written. It's in second stage, I had given just a spinal. You know what she has written? It is in Kannada. You may not be able to understand. If labor is so simple, if labor is so painless, I can deliver 10 times. That is what she writes in her comments. There is also spinal morphine. I don't know. It has not taken off. 300 mics at around 6 centimeters, 5 centimeters dilated, it seems. Intrathecal may not work as much as the other techniques work. So in all other cases, it is continuous epidural only. So we have combined spinal epidural, indications I told you, single shot spinal, indications I told you, and epidural in all other situations. Right. Now, you have decided on epidural. Now, when to institute epidural? When to start it? That's the big question. Whether it is early in labor or late in labor. So, all these problems started in 1950s in the US, when the women's liberation was at the peak. That is when this problem started. The women started asking, I only have labor pains. My husband does not have it. Now, why should I bear the pain? There is no reason. I don't want the pain at all. You give me epidural first, and then I go into labor. So there are reported instances wherein people have placed the epidural catheter and the patient has not gone into labor for the next 3 days. There are reported instances. So that is how it was so much misused for some time. So if you see the perineal floor structures, the tone of the perineal floor muscles, the tone is so important for the rotation and descent of the head, and also for the cervical head to nicely cervical dilatation. For all these things, the tone of the perineal muscles become very important. And those were the days when they were using 0.5% bupivacaine or sometimes 0.25% bupivacaine only. And so much of muscle relaxation, they could have done a caesarean section after that. So with so much of relaxation, the labor did not progress in many instances, and the incidence of caesarean section increased whenever they gave epidural early on. So what they did was, they came with an empirical figure of giving epidural only after 5 to 6 centimeter dilatation. Now, when this happened, what has happened is, supposing if Prime is in labor, she is in labor for about 12 hours, say, 12 hours labor, out of which she reaches 5 to 6 centimeter dilatation at around 9th hour. And then within 3 hours, she will deliver. So if you keep the empirical figure of 5 to 6 centimeter dilatation, the most part of 2/3 of the labor pains, she would have experienced it. She would have borne that pain, and then only she gets the analgesia. So this also did not become very popular. So the AACOG then came with a recommendation. They started telling that a person should be in active labor and there should be demand from the mother. I want epidural. And that is when you should give epidurals. So this is the recent concept is that maternal demand is good enough to give epidurals. And there is one concept known as maternal satisfaction. Now, what happens if you give very early? Whenever the moment the mother asks, you give it. What happens to it? See, maternal satisfaction is a very, very complex phenomenon. Good analgesia alone will not ensure maternal satisfaction at all. Finally, this book has arrived in the market. It's volume 1, you see, Understanding Women. Now, understanding women itself is so difficult. Now, you tell me their satisfaction. What will happen? So, people who have experienced real hunger, only those people know the value of food. For others, many things matter. Taste, ambience, company, many things matter. The value of food is never understood. Similarly, only those who have experienced strong labor pains appreciate the value of relief from pain. See, that is why maternal satisfaction is a very complex phenomenon. I'll give you one example of 2 sisters who delivered on 2 consecutive days in our hospital. One with and one without epidural. 2 sisters. See, the one who took epidural had excellent analgesia. Whenever I asked her, do you have pain? Her pain scores were near 0 only. But to my surprise, the one who took epidural was satisfied at all. Then retrospectively, she appreciated the itching more. And the mattress on which she was lying down to deliver was not good. She couldn't sleep at all. These were her complaints, not the analgesia. Mattress was bad. So in our institution, we have made a rule. We follow maternal demand for labor analgesia, but we make them demand a little late. We tell them, you're a strong lady. Hey, you can appreciate, your pain threshold is very high. You tolerate it a little. थोड़ी देर के लिए सहन हो ना. You need to enjoy the pains also. And then when she is almost not ready to accept, that is when we place the epidural catheter. And she knows what relief from pain is exactly. So weigh the advantages and disadvantages before you take a decision. Now, the next question is, you have decided to place the epidural catheter, and then you have decided, now I'm placing the epidural catheter. Where to place the epidural catheter? Which level? Whether to place it, the pain pathways, we all know in first stage it is T10 to L1, you see, thoracic. Why not place the epidural catheter at the thoracic level? So that is what we may think. Or place the epidural catheter in L1-2, L2-3, L3-4, L4-5 in lumbar area. Or place it in caudal. Where to place is the question. So if you see the pain pathways in labor, in first stage, it is T10 to L1, and it is thoracic, mainly thoracic, lower thoracic segments. L1, T11 and 12 in the early stages, and the one segment on either side gets recruited as the pain labor progresses. So that is in the first stage pain, and this is mainly visceral in nature. In second stage of pain, see, this is what the first stage of pains. In the second stage of pains, it is from the cervical dilatation and the perineal structures distending, and this will be to the sacral segments, S2 to S4. So in second stage, S2 to S4 is added to the thoracic segments, T10 to L1. T10 to L1 pain is also there, and the second stage is recruited. So this is a very important concept that one should understand. So the dermatomal areas of the second stage. So first stage, we need to block high up. Second stage, we have to recruit these sacral segments. For this reason, if you place very low catheter, first stage pains are difficult to achieve, difficult to obtain. If you place a high up catheter, second stage pains cannot be obtained. So for that reason, the best method is to place it in the L2-3 or L3-4 or L4-5, whichever space is the best felt is the best place to place the epidural catheter. Okay. Now you have decided on where to place the epidural also. Now the question is how to identify the epidural space. There are two techniques to identify the epidural space, as you all know. The first one is the negative pressure dependent, and the second one is loss of resistance. Negative pressure, where I mean the negative pressure that is there in the epidural space, that is made use of to locate the epidural space. The second one is loss of resistance. Loss of resistance, when I say, is not the loss of resistance for the movement of the needle. No, it is the loss of resistance for injection of a fluid, either air or saline. Now that has to be appreciated. These are the two techniques. The negative pressure dependent techniques like the hanging drop or the epidrum, all of them often fail. They do not work at all in pregnancy. The reason is that the epidural pressures in non-pregnant ladies is -2 to -4 centimeters of water, non-pregnant females. Whereas in term pregnancy, the pressure is positive. It is 2 to 4 centimeters of water. So how can you appreciate the negative pressure? And mind you, during contractions, the pressure may go up to 60 centimeters of water. Supposing if a patient is in labor and you want to place the epidural catheter and you try to use the negative pressure, and if she has contractions at that point when you are piercing the needle, the pressure would be 60 centimeters of water. So you cannot identify the space by negative pressure techniques at all. So what is the right one is the loss of resistance technique. Now, when I say loss of resistance technique, Is it loss of resistance to air or loss of resistance to saline? The saline techniques, loss of resistance to saline is a wonderful technique. I have been using it right from 2014 onwards. So before that, I was using air, and I've shifted from 2014 onwards. Now, this is one of the, I think, just watch the, this is air, okay? Loss of resistance to air. What I'm doing, you just watch. So I'm trying to elicit the loss of resistance. Every millimeter by millimeter, I am pushing the needle and then trying to elicit the loss of resistance. So while the needle punctures the epidural space, I am not eliciting loss of resistance. I elicit a little later. Okay. Now, you see, this is the loss of resistance to saline. Now, here what I do, you just watch. This is what the technique which I am using it nowadays. So I have connected the syringe. Now, watch carefully. See, I am using the entire unit, you see. This entire unit, needle I am not pushing at all. The syringe barrel I am not pushing. I am pushing from the piston. The point is that there will be resistance to push the saline into the ligaments. The moment the ligamentum flavum is breached, the needle stops moving and the saline starts getting pushed. Just watch. See, I am pushing the entire unit, and the moment the ligamentum flavum breaches, the whole unit stops, the needle stops moving, and the saline starts getting pushed. See, this is what happens. So this is dynamically at the time when the ligament is breached, the loss of resistance is demonstrated with loss of resistance to saline technique. Okay. So there are differences between the two. There is literature evidence, level 1 literature evidence to say that the incidence of accidental dural puncture is very little with loss of resistance to saline compared to air. So the reason is that when you are trying to using the normal saline, saline technique, you see the saline gets pushed the moment the ligament is breached. So this pushed saline will push the dura away. When the dura goes away and the needle stops shut. And this is the reason why the chances of accidental dural puncture is less with saline compared to air. The incidence of patchy block is definitely a possibility with the higher with air. The reason is that if you push too much of air into the epidural space in an attempt to demonstrate loss of resistance, later on when you push the drug, the air that is there in the epidural space will form pockets. Now, these air bubbles, if they are around a narrow root, then the local anesthetic cannot come in contact with that particular narrow root. And that one particular narrow root may escape. And that is when you may get a partial failure, patchy block. And quite obvious that pneumoencephalus and air embolism has to be a part of the air rather than with saline, very truly. There are two problems with the saline. Number one is learning curve. When you want to learn, shift from loss of resistance to air to saline, it's a little difficult. You need to apply your mind. And you must have that, that block, mental block. None of us want to come out of the comfort zone. We are pretty happy locating the epidural space with air, you see. So why change? Now, this trying to get out of the comfort zone is difficult. And that's one of the reasons why we don't shift to loss of resistance to saline. The most important reason is confusion about the CSF or saline. So whatever the technique that you are choosing, either loss of resistance to air or loss of resistance to saline, you can choose. I don't say that loss of resistance to air is a bad technique. I'm only comparing it with the loss of resistance to saline and telling that it's slightly a superior technique. That's all. But if you are using air. Don't push too much of air. That is the most important thing, the take home lesson that one should learn. So, take home message is that is relief of labor pains is required. What is the effect of teamwork on obstetric analgesia? Different techniques that are available: single shot spinal, the continuous labor epidural, and combined spinal epidural. Ideal labor analgesic, what should it contain? Which technique to choose? How to choose between these three techniques? When to institute the epidural? Where to place the epidural? And technique of identification of the epidural space, loss of resistance to saline or air. So these are the few issues which I have talked today. And in the next session, I'm going to talk about the drugs used in epidural, different combinations, first dose of the epidural, maintenance dosage, second stage pains, troubleshooting, continuous infusions, and incidence of LSCS and instrumental deliveries, and solo practice. These are the issues I'm going to discuss the next week.
Thank you.